Hello everyone. Now we shall discuss one of the most fascinating topics of neurology, that is peripheral neuropathy. Peripheral neuropathy can be broadly divided into various categories like neuronopathy, ganglionopathy, axonal neuropathy, and demyelination neuropathy. Neuronopathy means when anterior horn cell of the spinal cord gets involved, it is called neuronopathy. Ganglionopathy is when sensory root ganglion, the sensory nerve which is entering the dorsal part of the dorsal horn of the spinal cord, it has a ganglion outside the spinal cord where the sensory root enters. There is a posterior root ganglion or dorsal root ganglion. When the ganglion gets affected, it is called ganglionopathy. When sensory root ganglion gets affected, it is called ganglionopathy. Axonal neuropathy is when the axon of the peripheral nerve is affected. It is called axonal neuropathy. Axonal neuropathy can be further subdivided into small fiber neuropathy and large fiber neuropathy. Small fiber neuropathy is when spinothalamic tract gets involved. It is called small fiber neuropathy because the spinothalamic tract contains the nerve fibers A delta and C fibers. These are thin. A delta fiber is thin myelinated fiber and C fiber is unmyelinated fiber. So these are called small fiber neuropathies. Large fiber neuropathy means when posterior tracts are involved, posterior columns are involved. It is called large fiber neuropathy because posterior tract contains fibers A alpha and A beta. These are thick myelinated fibers. So axonal neuropathies are divided into small fiber neuropathies and large fiber neuropathies. Under small fiber neuropathies, we have spinothalamic tract involvement, which contains A delta and C fibers. C fibers are the unmyelinated fibers and A delta fibers are the thin myelinated fibers. Large fiber neuropathies, posterior column involvement, which contains A alpha and A beta fibers, which are thick myelinated fibers. And small fiber neuropathies are length dependent, which means the distal parts of the nerves, suppose the nerves innervating at the feet are getting involved. Distal parts of the distal nerve endings getting involved. They are length dependent. Small fiber neuropathies are length dependent neuropathies. Under demyelination, we have loss of myelin. This results in decreased saltatory conduction. Coming to patterns of peripheral neuropathy, there are 10 patterns of peripheral neuropathy. There are 10 patterns of peripheral neuropathy. The first one is symmetrical proximal plus distal weakness with sensory loss. So in the first pattern, there is symmetrical proximal and distal weakness with sensory involvement, which is seen in demyelinating neuropathies. The best example is AIDP, which is a variant of GBS, Guillain-Barré syndrome. AIDP, that is acute inflammatory demyelinating polyradicular neuropathy. The second pattern is symmetrical distal sensory loss with or without weakness. So in the second pattern, we see symmetrical distal sensory loss with or without weakness, which is a pattern for small fiber neuropathy. Small fiber neuropathy. The best example is diabetes mellitus. Diabetes mellitus is the most common cause for small fiber neuropathy. Other causes can include HIV, leprosy, etc. So here it is a small fiber neuropathy is a length dependent neuropathy. So there is distal sensory loss and it is symmetrical, and there can be weakness. Motor symptoms can be minimal, so there may be weakness with or without weakness. The third pattern is asymmetrical distal weakness with sensory loss. So here there is asymmetrical, that is either only in one limb, and distal weakness. Weakness is distal with sensory loss. This type of pattern is seen in radiculopathy. Radiculopathy, that is whenever a spinal root is involved, there is involvement of that particular distribution of that segment of that particular root is getting involved. In case of asymmetrical distal weakness with sensory loss, radiculopathy. And the other example is mononeuritis multiplex, where there is patch asymmetrical involvement. And the fourth pattern is asymmetrical proximal plus distal weakness with sensory loss. This is seen in polyradiculopathy and plexopathy, which is mostly due to malignancy. So here asymmetrical proximal and distal weakness with sensory loss. If it is symmetrical proximal plus distal weakness with sensory loss, then it comes under demyelination neuropathy. If it is asymmetrical and involving both proximal and distal part of the limbs, there is weakness, and with sensory loss, it indicates multiple roots are getting involved, and it is asymmetrical because whenever radical gets involved, it is asymmetrical. So multiple segments are getting involved. So proximal plus distal weakness with sensory loss, polyradiculopathy and plexopathy are the best examples. The fifth pattern is asymmetrical distal weakness without sensory loss. That means here only pure motor involvement is present without sensory loss, and it is asymmetrical in nature. Asymmetrical distal weakness, which points out anterior horn cell involvement. That is, anterior horn cell gets involved in case of amyotropic lateral sclerosis. So this is the fifth pattern. Now coming to sixth pattern, that is symmetrical sensory loss with distal areflexia and UMN features. Here the sensory loss is due to small fiber involvement. Here the sensory loss indicates small fibers are getting involved. small fibers involvement. Distal areflexia indicates large fiber involvement. Large fiber involvement. And human features indicates spinal cord involvement. Spinal cord involvement. This pattern we see in vitamin B12 deficiency or vitamin E deficiency or copper deficiency. So this type of pattern is seen in vitamin B12 deficiency, E deficiency and copper deficiency. Now the seventh pattern is symmetrical weakness. Symmetrical weakness without sensory loss. That means the weakness is symmetrical but there is no sensory loss. Here it is pure motor involvement without involving the sensory part. So this condition we see in myopathies. Okay, and rarely in anterior horn cell involvement, that is spinal muscular atrophy. We see this type of pattern. Now coming to eighth pattern, that is focal midline proximal symmetric weakness. Focal midline proximal symmetric weakness. It can be neck extensor weakness, bulbar weakness or diaphragmatic weakness. Which is seen in ALS, amyotrophic lateral sclerosis. The ninth pattern is asymmetric proprioceptive loss without weakness. Asymmetric proprioceptive loss without weakness. Whenever we see proprioceptive loss and the asymmetry, the ganglionopathy should come to our mind. Ganglionopathy. In ganglionopathy, we see this type of pattern, that is asymmetrical and proprioceptive loss without weakness. Seen in ganglionopathy, that is when posterior root ganglion getting involved, we get ganglionopathy. Most commonly seen in Sjogren's syndrome and paraneoplastic syndromes. Now coming to the last pattern, that is autonomic signs and symptoms. Peripheral neuropathy with autonomic signs and symptoms. This is seen in idiopathic pan dysautonomia, which is a variant of GBS, Guillain-Barré syndrome. You see autonomic signs and symptoms with peripheral neuropathy. Also seen in porphyria, diabetes mellitus, and also in HIV. So these are all the patterns of peripheral neuropathy. Coming to nerve conduction studies in axonal and demyelination neuropathies, the first one is CMAP amplitude. CMAP means compound motor action potentials. CMAP is compound action motor potentials. In axonal neuropathy, the amplitude of the compound motor action potential is reduced, whereas in case of demyelination neuropathy, the CMAP is normal. SNAP is normal. SNAP, that is sensory nerve action potential, the amplitude of sensory action potentials in case of axonal neuropathy are reduced. In case of demyelination neuropathy, it can be normal or reduced. Mostly it is normal in demyelination neuropathy. So the sensory and motor action potentials, the amplitudes of motor and sensory action potentials are decreased in axonal neuropathies, and whereas they are normal in case of demyelination. Now coming to distal latency. Distal latency, in case of axonal neuropathy, the distal latency is normal, whereas it is prolonged in case of demyelination. Coming to conduction velocity. Conduction velocity, it is normal in axonal neuropathies and it is decreased, drastically decreased in demyelination, because we know that this is a neuron where there is myelin. This is a cell body with dendrites. This is the nerve terminal. Here is the myelin. The impulse which is started here conducts and it jumps from one node of Ranvier to other nodes of Ranvier in this jumping fashion. This is called as saltatory conduction, which imparts the increased velocity to the nerve impulse to conduct fast. So this jumping mode of transmission is called saltatory conduction. Due to the loss of myelin in demyelination conditions, demyelination neuropathy, this saltatory conduction is lost. So the conduction velocity gets reduced in case of demyelination polyneuropathies. And conduction block. Conduction block is a feature of demyelination neuropathy. In demyelination, conduction block is present, whereas it is absent in case of axonal neuropathy. The sixth one is temporal dispersion. Temporal dispersion is absent in axonal degeneration, whereas it is present in segmental demyelination. The seventh one is F wave. F wave is normal or absent in axonal neuropathy, whereas it is prolonged or absent in demyelination neuropathy. Coming to H reflex. H reflex is whenever a muscle is stimulated, the impulse goes to the reflex arc to the spinal cord, and then from the spinal cord it again reaches to the motor nerve. This is the H reflex. This H reflex is normal or absent in case of axonal neuropathy, whereas it is prolonged or absent in demyelination neuropathy. So these are all the nerve conduction study differences pertaining to axonal and demyelination neuropathies. Thank you.